Thanks, Mark, for the kind introduction. And before we move to my presentation, so I'd like to thank everyone for joining us. We're going to be starting with a small video. And I also just want to tell our community colleagues the reason we were rushing you was not to get you off the stage. It was because this event is actually being live streamed around the country, and we needed to keep it on time. So we wanted to make sure that people that were calling in and watching from around the country would be able to join us on time. So thanks for understanding that. And so with that, we'll move to our video before we introduce the blueprint.
Tell me everything you know about hepatitis C.
About hepatitis C, basically what I read in the paper, not that much. You can get it through bad water in different countries.
I think that it's there's particular places in the world when that's a big issue, but for what I understand, not as much in Canada.
I can't tell you anything.
Have you ever heard of hepatitis C?
No. I know it's contagious. I know there's hepatitis A, B. C you don't hear too often about.
A lot of people, like when they go to Caribbean, they get it. I know there's a needle you can take for it, isn't it? Hepatitis C.
I actually don't know much. I think they give you shots for it in high school. I'm not sure. I think I got a needle for it.
But you can be vaccinated against it.
Yeah, I think I had like 2 or 3 weeks ago.
The issue of hepatitis C, I didn't know it was an issue.
En tant que bébé en Pologne, une transfusion sanguine au cours d'une intervention chirurgicale, une intervention à l'hôpital en tant qu'adolescent.
तो जो ही मुझे मेडिकल कार्ड मिला, ये तकरीबन बात है 2015 दिसंबर की, तो मैं फ़ौरन जो भी डॉक्टर करीब तरीन था वहाँ चला गया. दैट वाज वो एक वॉक इन क्लिनिक था. तो वहाँ पे डॉक्टर को मैंने बताया कि मुझे ये सिम्टम्स है. तो उसने कहा कि अच्छा मैं आपका फुल चेकअप करता हूँ. तो जब उसने फुल चेकअप किया तो उसने मुझे बताया पहली दफ़ा कि आपको हेपेटाइटिस सी है. ये मुझे डॉक्टर ने बताया कि आपसे पब्लिक हेल्थ वाले रब्ता करेंगे. तो इस बात को सुन के मुझे काफ़ी मैं परेशान हुआ इस बात से, क्योंकि मुझे लगा कि शायद ये कोई ऐसी बीमारी है जिसमें शायद किसी मरीज़ को अलग कर देते हैं, या मुझे ये तक ख्याल था कि चूँकि मैं यहाँ पे नया हूँ तो शायद ये मुझे कहें कि भाई आपको ये बीमारी है तो आप इसका इलाज करवाएं. इस तरह की बहुत सारे वसवसे, बहुत सारी जो है ख्यालात वो मुझे आए. तुम्हारा इलाज जो है वो नर्स जो है, तो तुम्हारा ज़्यादा राब्ता जो है वो हमारी नर्स से रहेगा. नर्स ने बताया कि आपको फैमिली डॉक्टर चाहिए. सबसे पहले आपका एक फैमिली डॉक्टर होना चाहिए. तो नर्स के कहने पे ही मैंने फैमिली डॉक्टर के लिए अप्लाई किया, और खुशकिस्मती से अब मैं मुड़ के देखता हूँ तो मुझे लगता है कि मैं बहुत खुशकिस्मत था कि मुझे फैमिली डॉक्टर बड़ी जल्दी मिल गया, और वो भी एक पाकिस्तानी फैमिली डॉक्टर मिल गया जिससे मैं आसानी से बात कर सकता था. तो उसके बाद फिर जो है उनका, मेरे फैमिली डॉक्टर का और जो स्पेशलिस्ट थे उनका लिएज़ॉन आपस में रहा, उनका ताल्लुक़ रहा, और वो एक दूसरे के साथ जो है मेरे बारे में जो भी नोट्स थे या जो भी टेस्ट के रिजल्ट्स थे उनका तबादला वो करते रहे.
Mon nom est Julie Bruneau, je suis professeure au département de médecine familiale et d'urgence de l'Université de Montréal. Je suis aussi médecin en médecine des addictions au CHUM, au centre hospitalier de l'Université de Montréal. Alors, l'hépatite C, c'est un virus qui se transmet très facilement. Chez la population des personnes qui utilisent des drogues par voie injectable, la prévalence est souvent plus de la moitié sont infectés. Et quand ils commencent à utiliser les drogues par injection, la plupart s'infectent dans les 3 premières années d'injection.
I experienced stigma from my own drug using community because I am an injection drug user, and there seems to be a hierarchy within the drug using community which injection drug users sit at the bottom of. But I've also experienced it like in terms of healthcare, not wanting to disclose to my family doctor for fear that I wouldn't get treated or I would get treated differently because that's very common. And just sort of that belief that feeling that you get from doctors and from healthcare providers that somehow you're drug seeking when in fact you're not.
Especially with the medical profession. As soon as I disclosed that I was on methadone, immediately you can see in the physician's eyes, male or female, uh-oh, this woman wants drugs. Support us, don't patronize us.
Focus on what we can do and teach us what we can.
See us, respect us.
Don't moralize us, normalize us.
Trust us until we give you a reason not to.
Give me an opportunity for growth and advancement.
Don't allow your fears and prejudices to stereotype us.
The only failure is to not try. We can all grow together from our mistakes.
See us, respect us.
Tell me everything you know about hepatitis C.
So with that, I think that clearly shows that there's a lot of work to do, and this was, we felt, a good introduction to introduce the blueprint, which some of you have heard about, and which it's my privilege today to be presenting on behalf of a large group of people who have been working on this. And what I'm going to go through today is what is the blueprint and how we take this, because I really want to make the point and really stress the point that this in and of itself is not the end. This is very much not even close to the end. This is really just the start of getting us moving on track towards hepatitis C elimination. And I think today really sets the stage for discussing this, because when we look at all of the things discussed today, it was heartening to see that most of those points are discussed in some way or another in the blueprint. And it's not a perfect document, but I hope we got the right tone with a lot of the key messages. So before I begin, I also want to acknowledge the traditional custodians of the land where we gather today, the Canadian Kaha Nation, and express our gratitude to the community and elders past and present. I also want to highlight the financial support for the blueprint effort. This has come from a CIHR network grant. We also did receive some support for communication efforts from CATIE, and we really can't say enough for CATIE's involvement in this whole process. They've been fantastic to work with, and this additional offer to give us some financial support for communications effort was over and above the call of duty, but thank you again to them. I do want to highlight specifically that there was no industry support at all for this effort, and the conflicts of interest of the writing groups is in the final document, and you can see that. I'm not going to go through them today. So what I'm going to talk about today is give you an introduction to what the blueprint is, and I'm going to talk a little bit about what we mean by Hep C elimination, so people are all on the same page when we know what we're thinking about, and then I'll go through the process, really thinking about the blueprint from the purpose, why do we do this, how is the process developed, what are the targets that we've tried to set out in this document, and then of course this came from the Can Hep C network, so it's important to remember that there's a lot of research gaps, and so I'm going to highlight a few research priorities. I won't go into huge detail about those, and then I'll mention some of the changes we've received after consultation. There's been a pretty broad consultative process to develop this document, and then I'm going to finish with next steps, because clearly this is not the end, this is really just the beginning of the process. So I don't think I need to have this slide for this audience, but it's important to remember where we're starting from, that hepatitis C is an enormous public health problem here in Canada. In fact, it's the public health infectious disease with the greatest public health burden of any, causing the greatest number of years of life lost in the country. And somewhere around 250,000 people are infected, but the truth is we don't actually have a great handle on that precise number. We know that a high percentage of those people have never been diagnosed, and a smaller fraction, a very small fraction, have ever received care or treatment for their infection. We know that certain populations in Canada are disproportionately affected by this infection, and I've listed them here, and I'll talk about them in more detail later. And I think the reason that we really thought about the idea of a blueprint is that although we have remarkable expertise across this country, hepatitis C prevention care and treatment strategies, while effective in small projects all over the place, are fragmented across the country. We don't really have a unified plan to move forward, and that's really where this came from. So before we go into the details of the document, it's important that we understand what we're all talking about, and I think most people now understand the concept of elimination, but sometimes the terms elimination and eradication are used interchangeably, and I want to make sure that everyone knows what we're actually talking about. We would love to get to eradication. Eradication means getting rid of every single hepatitis C virus on the planet. Unfortunately, that's not likely to happen. We've only been able to do that with one human infection ever, with smallpox, and the key point about that is that it means that we don't need to have any ongoing surveillance or control efforts. So if we get to eradication, we're really done. But this is very likely impossible without a vaccine, and even with one, it would be a major challenge. Elimination is a different goal. Elimination is not trying to get rid of every single Hep C virus, but it's trying to get it under control. So decrease either the regional, or in our case, what we're aiming for is the national prevalence to below a threshold to limit its impact as a public health problem. And a key point about this, and it's important not to forget this, that as we move towards elimination, we need to continue with ongoing surveillance and control, because otherwise we're just going to go down and come right back up. So that's something where we can't get apathetic as we get closer to elimination, and we will need ongoing efforts to maintain it. And this is definitely a challenging goal, but I think it's feasible with the right tools. And we talked a lot about the various tools that we have today to get us there, and there's no question that this conversation doesn't even start until we have the treatment. But I think we tend to focus too much on the treatment, and we heard today in looking at some of the other tools that we need to get there, we're really struggling with diagnostics, and we're really struggling with prevention. We definitely have good tools, but these tools are definitely not optimized, and unless we improve them and get them to the status of perfectivir on the treatment side, we are going to struggle to get to elimination. So everyone's seen these WHO commitments, and Canada, importantly, is a signatory to this commitment to get to viral hepatitis elimination. But when most of the slides show this, they stop there. They just show these two endpoints of getting to a 90% reduction in new infections and a 65% reduction in mortality. And these are absolutely key goals, and it's important to focus on them, but it's also important to dig a little deeper, because to get to these outcome goals, we need to do a lot of things along the way. And one of those things is that we need to have a national action plan, and I'm going to talk about that in some detail. The reason we need that is because when we look at where Canada is in the world, we're not doing so well on this front. I think generally Canadians are pretty proud of our healthcare system. We generally have a great healthcare system. We're not failing completely on hepatitis C, but we're definitely not on track to get to hepatitis C elimination. When we look around the world, you see these countries highlighted in green. Some of these countries are going to eliminate before 2030. Some are going to eliminate around 2030. And the ones in red, which unfortunately Canada falls into, it's not really clear if we're going to do it at all. And if we are going to do it, it's very unlikely to happen before 2050. And I think when we as Canadians look around the world, we'd like to think of a lot of things we do well, and we like to put our healthcare system as one of the things near the top. And right now, I don't think any of us are very happy that we're falling somewhere near the bottom of this list. But when we look at the countries that have done well with this, the key factors that they've had to get them there, they all have national action plans. They have key, strong political support to maintain and implement those national action plans. And they also have strong public health systems which are adequately funded and resourced to make sure that they can deliver a public health strategy to deal with a public health problem. So let's dig a little deeper into these World Health Organization goals for elimination. The first two are the impact targets, and those are the ones that everyone focuses on, the 2030 goals for reduction in new infections and mortality. And it's important to remember that these goals are for viral hepatitis. They're not only for hepatitis C. And when we break that down, the 90% reduction in viral hepatitis is actually a 95% reduction for hepatitis B. And that's recognizing the fact that hepatitis B has a highly effective protective vaccine, whereas for hepatitis C, we don't have that. So the goal is actually to reduce new infections to 80%. But the mortality goal is still the same, a 65% reduction compared to levels at 2015. Of course, you need to know your levels at 2015 to even be able to hit that target. But then there's a key second page to the document, which I think often gets skipped over, which is what do you need in terms of service coverage to get to those impact targets? And I haven't listed them all here. I've highlighted a few. Things like blood safety and safe injections, Canada's actually doing extremely well on those already. So these are obviously not a priority for us because we already have a highly functional public healthcare system in many ways. We talk about harm reduction, and the WHO focuses on needle syringe programs. And what I want to highlight are these numbers for a moment, because you're going to see that the numbers that are in the blueprint actually differ significantly from these. We're aiming a little bit higher. So these numbers aim for 200 needles and syringes for every person who injects drugs per year, and to get to 300 by 2030. But the goal of that was actually 50 or 75% coverage. Now, when you just think about this in terms of injection safety, there needs to be a clean needle and syringe and drug equipment for every single injection. So obviously you need to get to 100, and in fact you need to get to greater than 100% to actually achieve successful harm reduction. And that's a point that I think sometimes gets forgotten, and why the targets actually might be too low. We need to have very high levels of diagnosis, aiming for 90% by 2030, and then high levels of treatment at 80%. But when we look at these global targets, it's important to remember that the WHO is thinking about the world. They're not thinking only about Canada, and so these are targets that are set for all countries at all income levels. And I'd like to think, as a Canadian, proud of my healthcare system, that we can aim higher than that for some of these things. So for many of these are really minimums, and I highlighted the needle syringe program, but I also want to highlight that some other targets that the WHO has set are clearly not the goal. They're just what was felt to be feasible and a minimum goal. And in some cases, we're doing very well. Our baseline already surpasses what the WHO has targeted for example, blood safety. But what they also say, and they're very specific about this, is that each country needs to be informed by these global targets, but then to develop practicable, ambitious national goals and targets. And they go on to say that the WHO service coverage targets are used as a guide. So these are not set in stone, they're used as a guide. But countries should develop their own targets, taking into consideration the context in their country, the nature and dynamics of the epidemic, and importantly, the populations that are affected. You also, of course, have to think about the structure and capacity of your health systems, and the targets really should be based on the best available data. And this is an important point, because sometimes people say, well, you know, your numbers, where did you come up with the numbers? Because sometimes the data are lacking. And sometimes we're always working with imperfect data, sometimes to greater degrees than others, but we have to do something. If we always use the excuse that we don't have perfect data, that leads to a position of moving nowhere. The other point that the WHO makes very clearly is that as we move on this path towards elimination, we need to monitor our progress. So we need to put in systems to be able to collect the data to actually hit these indicators and really measure our progress. And if we don't do that, we really don't know whether we're on track. And then a key important point is that they specifically say that these targets need to apply to everyone. So it doesn't mean that you can end up with an average. It means you have to make sure that you're hitting that target in every population within your country. So the process that led to the blueprint is that for many years I've been coming to Canadian Liver Meeting, or in its former iterations, and I've been going to the Can-Hep-C conference, and every year we talk about the fact that Canada doesn't have a national action plan, and we've really struggled with this. And there are some good reasons for this. There's some challenges with developing a national action plan in Canada. We have some jurisdictional issues. As all of you know, healthcare is a provincial and territorial matter for most individuals in the country. And as a result, the federal government has never felt it's in the position to mandate the provinces to do something. Well, that's fine, but to some degree that also leads to a bit of inaction. The other thing that's a challenge, and this is, I think you could debate this, reasonable people can disagree on this point about whether we need disease-specific or more syndemic approaches to developing a strategy. So are we thinking about diseases that come together, or are we focusing on Hep C alone? And those two major issues have really prevented us from moving forward on developing a national action plan. So last year at the inaugural Canadian Liver Meeting, when it was finally separated as its own unique meeting, we started to have some more discussions about this. And Can-Hep-C, which is a national research network focused on hepatitis C, we felt that if there's anyone around the country that can at least provide some guidance to developing this, we can do that. Maybe we can't tell provinces and territories what they have to do, but we can certainly inform some useful information about how and where what we need to do to get to elimination. And so our goal was to try to develop a document that would not be the only document that guided us towards elimination, but would complement other efforts, not replace them, and would be a tool that could then be used to be able to actually lead to elimination in the country. So importantly, the Public Health Agency of Canada has also taken some key leadership here. They've stewarded the development of the Pan-Canadian Framework for Action to Reduce the Impact of Sexually Transmitted and Bloodborne Infections, or STBBIs. And they have done this and really developed a nice, and I would encourage you to read it, a helpful document on thinking about STBBIs in a broader framework. So there's obviously a lot of interaction between these related infections. And they've done this by integrating it across 4 pillars of prevention, testing, care and treatment, ongoing care and support. And we certainly didn't want to ignore this document because it's quite helpful. And in fact, what we wanted to do was try to complement it. But we also recognized that there are some unique points about hepatitis C which distinguish it from some of the other sexually transmitted and bloodborne infections. The unique factors are not unique in and of themselves, but they're unique in their combination. So the fact that this is a curable disease or curable infection and that people have broad access to therapy is one of the key points. A high proportion of people remain undiagnosed, and there is rising morbidity and mortality now without action. And if you look at it across the other STBBIs, there's no other STBBI that meets all 3 of those criteria, and that is what makes hepatitis C a little bit unique. That being said, we recognize that it doesn't make any sense to work on hepatitis C and ignore the other things. So this is definitely thought to be that STBBI should be thought of comprehensively, and we should be, as much as possible, trying to use established infrastructure, sharing implementation, and certainly evaluation processes across the spectrum of STBBIs. And one of the things that we did last year at a workshop was we looked at where Canada is, what do we need to do to get ourselves on track? And we did a modeling exercise which was really led by Naveed and Mel from BC, who have really developed the BC Testers cohort most of you are familiar with. And they plugged in data to look at what happens if we continue to do what we're doing or if treatment numbers start to fall off. And I would say this is a bit of an optimistic scenario because if you look at this, you see that if we maintain the high treatment rates that we hit in 2016 when we were at the peak of treating hepatitis C in this country, and if we just continue to do that, no problem, we actually meet the targets. The problem is that if we don't do that, it's the blue line is what happens. And what we've seen all across the country in all of our clinics is we're starting to see not increasing rates of treatment, but actually decreasing rates of treatment. And if we do that and we have rapid fall off of the treatment rates in the country, we're not going to come anywhere close to elimination, and we're actually going to start to see rising mortality related to hepatitis C. So I think the problem with this is that it sounds easy to just say we just have to do what we're doing, but continuing to maintain treatment at the levels that we are at even today, let alone 2 years ago, is becoming more and more difficult because to meet those targets, you have to continue to find the number of people, engage them in care, and provide them with treatment, and that becomes more and more difficult over time. So that's where I think CanHepC thought we could provide some help. And for those of you who are not as familiar with CanHepC, this is a research network that CIHR funded and receives funding from the Public Health Agency of Canada, which includes 4 research cores, the basic science, clinical, epidemiology, and policy core, as well as a key training core and a knowledge translation core. And we do a lot of work in different areas of hepatitis C, and many of you attended the symposium today, which is really, I think, a pretty unique symposium that it covers all of these different areas of hepatitis C research. And although CanHepC, I guess we can say we've probably led the charge on the blueprint, this has definitely not been a work in isolation. We've worked with a huge number of partners and stakeholders across the country. This is only a small number of them, but we really do want to send a huge thank you to everybody who's helped with all of the efforts moving forward on developing the blueprint. So what did we try to do when we set out to do this? Well, we said we wanted to make a policy tool that would complement the Pan-Canadian STBBI framework. We also said that we wanted it to provide guidance, but not just guidance. We wanted to make sure that it actually had specific and measurable objectives and targets. And that's key, that there has to actually be something you can look at and say, did we hit the grade? And to do that, one of the things we were really tried hard not to do was say, how do you have to do this? So there's lots of different ways to achieve the same goal, and we recognize this, and so what we have in the document are suggested activities, and what we've defined as good practices rather than best practices, because what's best today may not be best tomorrow, and certainly what's best today may not be best somewhere else, and the WHO has really pushed to try to use the term good rather than best practices, and we've done that in the document. And then, of course, as a research network, we also wanted to provide a research agenda. And an important part of all of the process was to remember an equity, not an equality, but an equity lens as we were thinking about how we were providing services to all of the populations. And the goal of this would be to support provinces and territories and the federal government to then develop their own specific action plans. And that's really the key take-home message, is this document is just a guide. It really does give information about what needs to be done, but how it needs to be done, there's some suggestions, but it's not prescriptive, and even who needs to do it in different regions may vary. So to the development process, after we decided to set out on this, we had people commit to this from the CAN-Hep-C network, and we reached outside of the network where we needed additional expertise and set up writing groups and working committee to have a section on prevention, testing and diagnosis, and care and treatment, as well as a working group specifically on priority populations, which I'll talk about in a second. We had a public webinar in French and English to get feedback on the process of developing this. We then held an open stakeholder workshop at the Global Hepatitis Summit last year in June. We then started writing the document, and when we had a draft, we sent it out for pretty broad consultation, initially with, again, a public webinar in French and English to highlight the nuts and bolts of the document, and then we made sure that the federal government and the provinces and territories were aware of the effort, and then tried to get feedback from as many stakeholders as we could by sending out this draft document. And we then tried to incorporate as much of that feedback as we could into the final document, which was formally put onto the CAN-Hep-C website today. And so what the document includes, it has some information about the global and Canadian hepatitis C context. It highlights some key points about the priority populations, highlights a key element that crosses all of them, which is stigma. It has a section on systems for monitoring progress, so we can track our progress towards elimination, some important points where the federal government has to play a role, and then a list of indicators to monitor our progress. And as I mentioned, the three key pillars of prevention, testing and diagnosis, care and treatment. We also defined priority populations in the document, and these were groups that either had a disproportionate burden of hepatitis C or had difficulty in accessing service for hepatitis C, or in some cases both. And the groups that were identified, and this was again with feedback from community members, were people who inject drugs, Indigenous Canadians, people with experience in the prison system, gay and bisexual men who have sex with men, older adults, and immigrants and newcomers to Canada. So in this document, which I think does differ a little bit from most other national action plans, we have specific recommendations and considerations for each one of these priority populations, and I think this is a useful tool in the document, and I really would give kudos to the Priority Populations Working Group, who spent a lot of time thinking about how to do this. And a key point that they highlight is that there's a lot of intersectionality. These groups do not live in isolation. Many people belong to more than one group, and sometimes that can make it even more challenging for them. So some of the just key principles in the document, we go through each one of these priority populations, but a few key principles that cut across all of the groups is that, as we heard today from our community members, that it's critical to involve priority populations in program development and program evaluation at every stage of the game. That we really need to consider a health equity lens as we do this, and we need to make sure that we bring services to where people receive other health and other community services, rather than forcing them to fit into the model of healthcare that we've traditionally provided. We need to consider intersectionality and syndemic responses, so we need to make sure we're thinking about other infections that may affect these populations, and we need to make sure that we provide these services in both linguistically and culturally sensitive ways. A key section in the document talks about stigma. We've heard a bit about that today, and I think this is taken, the first quote is taken directly from the framework, where they've said it nicely. Everyone can access culturally appropriate, stigma-free. They talk about STBBI, we talk about Hep C prevention, care, and treatment. And one of the key things that we recognize is we actually don't have good ways of measuring stigma for hepatitis C. There have been some nice tools developed for HIV, which can be adapted, but that we really do need some Hep C specific tools to measure stigma if we're going to be able to see our ability to change and reduce stigma. And we definitely need to help train healthcare providers. We heard in the video that that can be a really stigmatizing event and a barrier for people to access care. And we also need some policy level considerations which reduce stigma, and one that we've specifically focused on is recommending decriminalization of drug possession for personal use, because, as we heard when we talked in the panel discussion, just the idea of the criminalization of drug of drug possession really is a stigma-producing factor. We also, in the document, talk about systems for monitoring progress. We really need good epidemiological data and HCV surveillance systems, and these need to be in place quickly, because unlike we need to hit these service targets over time and get to the outcome targets by 2030, but the only way we're going to know if we're making any progress is if we put in these monitoring systems quickly. So we've really called for these to be hopefully in place by next year or shortly thereafter. And ideally, we should be able to link our surveillance data with provincial and territorial administrative health data, like has been done in British Columbia and Ontario to some degree, to be able to really understand what's happening in the province. And then we've called on the Public Health Agency to support an annual conference to be able to share best practices between the provinces so we can actually see what we're doing and actually move forward with some of these processes. A few additional recommendations for the federal government are to fund and implement harm reduction interventions across a number of different types of harm reduction interventions. I mentioned the drug policy reform, and then to make sure that they think about hepatitis C and other sexually transmitted and bloodborne infections as they think about policies to address the opioid epidemic and the overdose crisis, which are very high on the agenda of the federal government. So I'm now going to go fairly quickly through the key tables in the document which highlight the key objectives and targets in each one of these three pillars, highlighting a few of the good practices and suggested activities that we'd like to see or we would suggest be considered to reach these. So the first is in the prevention pillar, is to reduce new HCV infections, and we've really taken this from the WHO document of aiming for an 80% reduction in new infections. We'd like to hit that earlier, but we want to make sure that we're there by 2030, and the truth is it's hard to measure incidence, and we don't have a great handle on this. We don't talk a lot about reinfections in the document, other than to say it's really hard to measure them, and at least initially, we don't want to set a target for reducing reinfections, because as we reach into harder to reach populations and higher risk populations and get them into care and treatment, we actually may see an increase in reinfections. That's not a bad thing. That means we're getting reach and care into populations with a high risk of infection. We hope to see that although it may go up initially, that by 2030 it will come down just like primary infections. You'll see that our needle syringe targets are higher than what the WHO has called for, and that's because of what I highlighted before, that we need to be above 100% in order to actually achieve safe needle syringe and to really maximize the benefit of harm reduction in terms of prevention of transmission. And then one of the things that's not in the WHO document, they don't actually talk about opiate agonist therapy. Canada's been a pioneer and a leader globally about introducing and making available opiate agonist therapy, and although we're doing it fairly well, we probably still need it still needs to be improved. And you'll see that our target is 40% initially for 2025, and that's a target which in truth is probably close to where we're at as a national average, but there's huge variability. There are some places where there's very low access and some places where there's very high. What we'd like to see is by 2030, not necessarily that the target's higher, but that it's more uniform, that everybody has access, and that there's a minimum of 40% access in every part of the country. So to do this, we need to scale up our harm reduction programs. We need to implement effective peer-based interventions. I think we heard loud and clear from the panel that can really help move these harm reduction programs forward. And then we also need to think about other harm reduction strategies like supervised consumption sites, which have expanded across the country recently. In the testing and diagnosis pillar, we're really focusing on making sure people get diagnosed, and not just that they get an antibody, but that they get through and have an RNA test done. So we want to make sure that the number of people living with hepatitis C who have been diagnosed is 70% by 2025 and 90% by 2030, so to meet that WHO target, but that we want to make sure everyone that has an antibody test goes on to get an RNA test. And our first look at the data in Ontario, as you heard earlier today, suggests that a lot of people get multiple antibody tests before they ever get an RNA test. And we want to make sure that doesn't happen anymore, so that every single antibody test leads to a test for RNA by 2030. To do that, we're going to need reflex testing, and that certainly can be implemented. But we also need to make sure that we continue to have centralized reporting, because as we start to incorporate some of the new point-of-care technologies, if we're actually going to track our data, we need to make sure that that data gets back to the public health office so we can really follow where we're at. And we really need to think about expanding our reach and access for testing, and think about task shifting so we don't rely on people coming to traditional healthcare facilities to receive testing, which doesn't need to be done there. And then importantly, we have really advocated for one-time testing among the baby boomer birth cohort, whether 1945 or 6 to 65 or 45 to 75. You can debate this a little bit. The data supporting this are in the document. I'm not going to go through it today, but we have done additional analysis to show that this is very cost-effective and also life-saving, so it's something we really should be doing. And then finally, the HCV care and treatment pillar, and there are a number of objectives here. So we want to make sure that the number of people diagnosed with Hep C who are linked to care and treatment and ongoing support is at 50% by 2025, and then meets the WHO target of 90% by 2030. That we increase the number of people with Hep C who start treatment, get to 50% by 2025 and 80% by 2030, and that ensure that we have high treatment completion rates, and we expect that most who complete treatment will achieve SVR. With this, we hope to reduce hepatitis C prevalence and then some of the burdens of hepatitis C, the number of liver transplants that happen in the country, and then ultimately get to our mortality goal of reducing this by 65%, the WHO target. So to do this, some of the suggested activities are to expedite linkage to care and initiation of treatment, and we heard some good examples of that today in the presentations. We need to increase the number and type of providers offering treatment. We need to provide treatment where other services are offered. We again heard about that today. Co-location of services is key. And then we need to make sure that we provide follow-up for reinfection and retreatment in a stigma-free way for people who do become reinfected. In the document, we also, for each pillar, highlight some key research priorities, and I'm not going to spend time going through them all. I want to highlight vaccine development. Canada is a leader in this. We really have some great expertise, particularly in Edmonton, led by Michael Houghton and Lauren Terrell's group. And this is something where we could, if we're actually going to get to eradication one day, we're going to need a vaccine, and this would be a huge boost for Canada if we could actually get to a vaccine development. So that's something we need to support and continue to push forward on. And then you can see a number of other things across the cores that we really need to continue to do research to really learn about what are the best ways to do things. None of these targets are necessarily static. As we learn more, we may actually adjust them based on better data. We sent out the document for feedback, and we got a lot of feedback, and thank you to many of you who did provide it, and thanks to others who aren't here for providing useful input to the document. And we made some key changes after that. So one thing is that we did remove youth and adolescents as a priority population. But I want to highlight the point that what we didn't do was take out any of the recommendations about youth and adolescents in the document. The reason people felt it wasn't right to keep them as a priority population was because the burden of hepatitis C is not that high, at least the data that we have. The reason we had originally proposed that they be a priority population was because they do have limited access to many of the services that adults receive in the country. I think this is a compromise, but the key point is that the recommendations are still all there, and so I think it's still serving the purpose and serving that community. We also got some feedback that we didn't highlight what was being done well in Canada, so we have highlighted some really excellent examples of programs that are going on in the country. It's not exhaustive, we just had taken a few good examples, but that's important. We tried to make sure that we had some further justification for things that people challenged us on for some of our targets. It's always a balance of putting too much in the document and making it unreadable versus making sure that the evidence to support the recommendations is there. So we've tried to beef it up a little bit. We also clarified about a question about the who. There were questions about who should be doing what in different levels of government, and the reality is this varies, so we couldn't be specific about this. This is something that each province has to figure out for themselves. We added the treatment and SVR targets as a recommendation, and we made many changes to the language in the document based on excellent feedback we received. So finally, how do we use this blueprint? Well, the first thing is I would highly recommend that you do not read it from start to finish. For those of us that have done that more than once, it's a long document. But the key point is that is why it's repetitive. We also got feedback that it is a bit repetitive. That's quite intentional because it's not meant to be read like a book. So we want to make sure that key elements are in the places where people are going to access information. I would recommend you look at those objectives and targets tables that I showed quickly, but look at them in some detail for all the pillars. And then in your own jurisdiction, consider who is responsible for what. So divvy up the responsibilities of those sections because it's going to vary. And then for the sections that are relevant to the work that you do, I would encourage you to read the whole section. There's some really useful resources and background information in the document. Look at the rationale for the targets and make sure that they make sense to you. Look at the suggested activities and consider what would work best in your setting and what's feasible. And then the indicators tables, which is at the end, is again, not something to be read as from cover to cover, but it's really important as a tool to be able to monitor what you're doing. So these are important as you implement things moving forward. If there are things that don't make sense in the document, this is not a finished product in a sense, and I'll show you what I mean by that in a second. So ask us, because we may have had a rationale, and also there's certainly things we got wrong. The key point, though, is that what the blueprint is for is it's not the end game. This is really just meant to be a guide for each province and territory, and ideally the federal government, then to develop a specific action plan for addressing hepatitis C elimination within their jurisdiction. And that's where, so in a sense, this is where the work just begins. So you really need to take this and then use it to work with your province or territory to develop an action plan. And so here are the links to the English and French version, which are now up on the CanHepC website, and I would encourage you to look at them. And then I hope that we will, moving forward, have an annual meeting, not this meeting, but a separate meeting to discuss specific progress of all of the provinces and territories on their path to elimination. And I'm going to finish by reminding us that this is really use this Winston Churchill quote to remind us that now is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning. So we're just getting started on track here, and I hope that this proves to be a useful tool to be able to get us on track to develop action plans and ultimately to achieve these pretty ambitious goals of elimination by 2030. And before I conclude, I really would like to acknowledge a huge amount of work that has gone into this effort, and I want to make a specific, I did it yesterday, I embarrassed her yesterday, but I'm going to do it again today, is Lorraine Fredette, who has been absolutely unbelievable in this whole process. She's the project manager at CanHepC, and in theory, her job was to help us navigate and develop the blueprint, but she did so much more than that in every level from proofreading to writing to providing great feedback and sitting through every one of our conference calls and helping us with it. Lorraine, thank you very much. I'm sure her partner will be very happy that this thing is done, because I was bugging her on a lot of weekends and evenings to get to work on this. And then I want to highlight all of the working groups, the prevention, priority populations, testing and diagnosis, care and treatment, and particularly to the individuals that you'll see there as indicated as the co-chairs. Most of these people were asked to serve in these positions and did a phenomenal job of really going back and iteratively reviewing the document and revising it, improving it, and revising it and improving it. And I think the finished product is really quite well done by all the groups. And a special thank you to Tracy Swan, who we commissioned to help us do the writing for this. And Tracy has a long experience of community involvement and work in the hepatitis C and previously HIV field. She's a fantastic resource for all of us and really did a huge amount of work to help us write and put together the document. And then once it was written in English, translation's not so easy, so thank you to our translators, and a particular thank you to Valeria, who did a great job. You'll see that the finished product online is quite beautiful, and she did a nice job with the design, which I will take zero credit for. And with that, what we're going to do now is call up a few members of the working group to have a short panel discussion and take any questions and comments from the audience. Thanks so much. So I'm going to call up, if Melisa, everyone's coming up. Melisa is from CATIE. You kind of know that you're coming up. And Lindsay is from PASAN, Lindsay Jennings. Bruneau from Université de Montréal, Mel Krajden from UBC, and Marina Klein from McGill University. And so, okay, so Melisa, tell me, so maybe I'm going to turn the floor quickly to Melisa and Lindsay, because they wanted to, yeah, please go ahead.
Thank you, Jordan. Everyone's excited to get out to wine, but we prepared something. So good evening, everyone. It's a pleasure and a real privilege to be here this evening to say a few words about the Priority Populations Working Group. So we were a group of 8 organizations and networks that work together with the broader writing team as part of the blueprint development process. And our purpose was to ensure that the views and issues that are relevant to priority populations were reflected in the blueprint. This includes the views of people who use drugs, Indigenous peoples, people with experience in the prison system, immigrants and newcomers, and people born between 1945 and 1975. And the composition of our core group and the reviewers that we worked with included people with lived experience, community leaders from these priority populations, clinicians, researchers, epidemiologists, healthcare providers, and lawyers. And we really came together from a diverse range of organizations, including South Riverdale Community Health Centre, CAPUD, CAN, Prisoners HIV/AIDS Support Action Network, the Canadian Liver Foundation, and the BC Centre for Disease Control, the Hospital for Sick Children, and CATIE, Canada's source for HIV and hepatitis C information. From the onset, we knew the importance of an approach that focuses on the needs of priority populations, and the term priority populations was selected intentionally and is meant to refer to populations and communities across Canada who experience a disproportionate burden of hepatitis C and really face challenges in accessing mainstream hepatitis C health and other social services, and therefore really stand the most to gain from a hepatitis C approach that's grounded in the principles of health equity. And we know that the priority populations approach in the blueprint will be essential to the success of the hepatitis C elimination efforts in Canada. And Lindsay Jennings was one of our members, and so I just want to invite Lindsay to share a few words and thoughts on her involvement in this process.
Thank you very much. Again, my name is Lindsay. I'm the Provincial Hep C Program Coordinator at PASAN, which is Prisoners HIV/AIDS Support Action Network. We do a lot of work within the provincial and federal institutions around HIV education, Hep C education, as well as harm reduction and overdose prevention work. I am also somebody with lived experience of being incarcerated before, and I do have a personal relationship with Hep C as well. So I can tell you that probably about 10 years ago, sitting in my jail cell, I did not think that this audience would have ever been in my future. But this experience has, it was very, very enlightening. I don't necessarily suggest deciding to sit in traffic in Toronto and take these conference calls. It's not always supportive, but it was eye-opening to be able to sit on calls, but also in rooms like this with people that realistically I never thought I would even meet or associate with. But also too, it taught me a lot around how planning has to happen and legal documents and how as a country we can come together and all the different lenses that we have. And so I know sometimes I probably could have added a little frustration to some of those phone calls, but that's just because I'm coming from a different lens of somebody that has lived through it and was able to, and really truly invited to speak my mind and to share my opinions and things that I thought may not work. And this blueprint, I mean, it addresses a lot of people, and Jordan talked about equity and for people that are covered under the healthcare system, but in Ontario, our prisoners are not covered under the healthcare system. So I think that was really important, and an important piece for me to bring to this blueprint was to talk about a population that sometimes gets ignored and that there's a lot of stigma involved with just having a criminal record or being incarcerated, and then on top of adding certain diagnoses or certain mental health concerns within a prison population.
Excellent.
Yeah.
So what I'm going to do now is open it up to the floor if anyone has any comments or questions. If they don't, I have a few questions for the panelists, but unless there's anything that any of you wanted to jump in with, but maybe I'll start by going to the mic. So, Heyman.
Hi there, Heyman Shah from Toronto. I only have a comment. So I liked everything you said, Jordan, except the part that there's going to be another meeting. But I actually
You won't be invited. Just kidding. Just kidding.
Your wife's going to hear about that.
Yeah.
I actually really want to just congratulate everyone who was involved in this, I think, monumental piece of work, something that Canada has now. and that I think it's a call to action for all of us in this room to take this blueprint, maybe not read it cover to cover, but use it as a resource for ourselves in the work that we do. And I think we all now have to become part of this movement to bring this blueprint to life. And I think it's a challenge to everyone here. So I'm happy the room is full, and I hope we're up to it. But congratulations again for the work.
Thanks, Dave. So that's a really important comment, because actually the first question that I had for the panel is, how are you going to take this? What are you going to do? And what would you recommend to the people in the room in terms of using this blueprint to actually get to provincial plans? So how do we move it forward from here? Mel, you have the answers, I know. Or Julie?
I'll just say a word, first of all, because we are in Montreal. Je suis extrêmement contente qu'on ait pu avoir la version en français et en anglais en même temps. Je peux vous dire que c'était assez... ce fut un travail épique parce qu'on a travaillé essentiellement en anglais et que la fin a été... c'est toujours à la dernière minute, hein, on finit quand on finit. Donc, je suis très contente. Merci beaucoup, Lorraine, d'avoir pris ça sur tes épaules. Ça veut aussi dire que au Québec, on va pouvoir avoir un document immédiatement à distribuer à tout le monde. And I think it's very important that people you're thinking in your jurisdiction, provinces, cities, etc., they have to understand the principle of these things, because these type of documents, they come and go, and there is the WHO, there is the Canadian, and I'm not involved in research, I'm in public health or at the ministry. And I think the key message, and I'm thinking of how to do it, and if people in Quebec have some ideas about this, please come to me. But the idea is, how do you bring this document to the people who are responsible for moving forward, and not feeling that this document doesn't belong to them, or they can't do nothing, or they have to go from scratch and begin again to reinvent the wheel again, because this document is really stopping where they have the power to do something. And if they can use it to then think about what they're going to do, then we're going to go much faster than if we're just going from scratch and write a new thing, or trying to take this but rewrite the whole thing again. And I think that's the idea, and probably the message I would give to everybody here is try to strategize and how to make sure that people understand what was the intent of this document, because it's the document for action, as you certainly said well.
I think an important point about that is that sometimes living in sort of our little Hep C bubble, we think that everybody realizes that the WHO is calling for elimination, that everybody knows about the treatments. And I can tell you, when there was a little bit of, we did a little bit of press coverage around this, and the questions people asked me about it were, what is hepatitis C? Is that like A and B? I mean, it was more like that video at the beginning, where, and unfortunately, sometimes people in government and policymakers are starting from that point. So don't assume that they know everything that's here, and don't assume that they already have a plan, because they probably don't. And hopefully this will help them. Mia, did you want to make a comment?
Can everyone hear me okay? There we go. So this question is more for the subcommittee on special populations and priority populations. Again, talking about overlapping populations, overlapping experiences, but just wondering around some of the thinking around folks who engage in sex work, and whether that was sex work by choice, sex work's not by choice, and then how those worlds certainly overlap and are meshed, and why that wasn't sort of considered in terms of priority population. Again, understanding sexual transmission is low, understanding lots of people who engage in sex work also engage in substance use, but just sort of wondering why that wasn't a separate kind of priority population.
Thanks. So we really looked at priority populations that are facing a disproportionate burden of disease in terms of the epidemiology. And within the document, there is some gender-specific content that we looked at within each of the priority populations. So there is some of that, but it wasn't teased out as a separate priority population.
Discussion about specifically about some of the rules, some of the laws around sex work. So that specifically is actually mentioned in the document, and that came to us from the legal the legal network that provided some input around that. So I think it's a key point, and figuring out exactly how to get it right is always a challenge, but it was really focused primarily on the disproportionate burden of disease, which I think all the groups that we've highlighted do have.
Yeah, I don't think the data is there, but I think from anecdotal data that the prevalence among those types of workers would be high. Thanks.
Yeah, no, that's a good point. Marina, did you want to?
I was just going to add to what Julie was mentioning about how to use this document and how we can disseminate it. One of the things that struck me, and even working in this field, I'm always looking for various numbers, various figures, various things to justify all the actions that we wish to place, and they're always very hard to come by. And you have to pull various different sources, and they're dated, and they don't all come together in one place. And what I think is beautiful about this document is that at your fingertips you have all those key pieces of information that can really speak to how important it is to address this problem now, and what the potential impact of addressing it can be if we do follow through with the blueprint actions that are suggested. And I think those were done in a way such that they would speak to, hopefully, policymakers that could uptake these interventions. In addition, I think the suggested activities and the not best practices, but good practices that we put out are quite practical. They're not pie in the sky types of things. I think we made an attempt to do that, such that these are actually, to the best part as we can do, evidence-based, but also really things that are feasible. And in that sense, I think with each section, depending on which area you're working in and how you're intervening with different people making decisions, I hope that this document can be used in those ways.
Mel, go ahead.
And in addition to thanking the entire group, I really do want to thank Jason Grebley, who's the co-chair of the testing group, and he always puts my toes to the fire and always pushes me to the end. And what I really enjoyed about today's meeting was this whole notion of one of the component pieces that's clear is that the testing is a gateway to engagement in care. And fundamentally, the care process has to be part of the testing planning process, and they're completely linked. What's also clear, and was discussed by many people today, is the system has an inertia, and to overcome that inertia, you really have to recognize that the system is now built on you going to a physician or a healthcare provider and then going to get a test. And what we need to do is totally change that and provide a suite of different opportunities for people to get the services they need. And then what's also clear is that this whole framework of STBBI is relevant, because if you see someone and they have the potential of having Hep C and Hep B and not testing them for both, that doesn't make sense. Or if they have an STI, same kind of thought processes to try to be opportunistic about each of those things. I know that I've argued with Jason specifically about this notion about what happens if you're losing someone to follow-up because they're not getting the testing. I think loss to follow-up means more than not getting the testing. It means that they're not getting the services they need in the way they need them. And I think we have to use this document to reshape how we think about how we provide services to this complex population, not only for hepatitis C, but for hepatitis B and the slew of STBBIs.
One of the things that I would say in my little experience so far of using the principles of the document in meeting with the Ontario government is before you have these meetings, think of some small, easy wins, because that's really helpful for policymakers. Look through the document and think about some of the targets that they're either already meeting and compliment them on doing that, or some targets that can be easily met with some pretty small changes. And that's the way to get the conversation started and get people engaged. And then ultimately you do need their buy-in, because really, again, this is not an action plan. This is a guide to develop an action plan. Brian's been a huge help in developing this, so I'm going to turn the mic to you.
So again, congratulations to all of us, especially the leadership of the movement here that has produced
this great document. I'm going to make 3 quick points. The first is one that Jordan has already made, is that we tend to overestimate the knowledge base of the people with whom we are interacting. And I think that to really make it very, very basic about hepatitis C, and something that I said on the radio 10 times today, Jordan and I did a whole bunch of radio pieces, is do you realize that today in Canada, 25 people will find out that they have hepatitis C? It sounds like an overall simplification, but if you do the arithmetic of the number of new cases that are out there, and that will attract the attention and will allow you to add on some very simple facts that may make the thing relevant. Policymakers like things that are relevant, and if it's relevant to them, and look through the document and find something that's relevant to the people that you are going to be talking to. And Jordan was saying, make 3 quick points or one. It's exactly that. The document, you just say, here on page 32, it says this, and this is relevant to you, Mr. Assistant Deputy Minister, or Mr. Leader of some community group. So I think that's what we're going to do. So the task that I would give us all, and if you act on things quickly, things get done, is in the next week, find 3 people that matter and explain something to them. And it'll be the first step towards trying to get getting things going. And I think it's this retail element that's going to really serve us better. And I will leave you on one other point. Anyone in this room who is for more stigma and discrimination, raise your hand. Okay, so we have screwed up a little bit in the HIV movement. Over a generation, we've tried to eliminate stigma and discrimination, and we haven't. This is giving us another chance, and put it in the context of STBBI. There is not a public official or a policymaker or anyone who say, I have a plan that's going to help reduce stigma and discrimination, and I'd like to talk to you about it. And we have a whole section on that, and I think this is going to help lead to a whole bunch of other things that will help us accomplish our goals. So I think it's a document that really speaks to people, and that what happened after the interviews today is usually they just hang up, thank you very much. And a couple of guys said, really? 25 people today? And it's sort of, yeah, do you want to talk some more? Do you want to talk again? I have other people, like Jordan Feld to talk to you about all sorts of other things. Do you want to book him for an interview? I mean, it's sort of build, I think, and we really have a unique opportunity to do so and to be completely relevant. And I always made it about this is to help all Canadians. It's not that, of course we have priority groups, but we want to help Canada. We want to help every single Canadian in both official languages, and any other language for that matter. But I think really it's about being passionate about this, and the document gives us this tool that helps us be passionate. So there's a pile of people behind me, so there you go.
Hard act to follow. Great, Brian. I want to congratulate all of you and all the people involved. It's really a good document and a good blueprint. I wanted to try to reinforce something that is mentioned in the document and we've all talked about, and gives a bit of an example why. In BC, and Mel's certainly aware of this as part of the testers cohort, there's been a huge number of people that have been lost to care after testing. And there's 2 points when that happens, and one is after antibody testing. Huge number of people, I think it's around 13,000 out of 50-some-odd thousand are lost to care, never receive any other care. And then at RNA testing, there's another roughly 13,000 that are lost to care. Now, it illustrates how important it is to engage people in care at point of care, meaning testing. And I think we all understand that. But I want to ask another question, which is how are we going to find those people that are already lost? If it is, in fact, 26,000 in British Columbia, what is it across the country or the world?
Well, our latest estimate in British Columbia, including the people who we think are not diagnosed, is that there are 32,000 British Columbians who haven't been treated, who need to be treated. And the challenge is how to come up with the solutions about how to reach out to those people who may be stigmatized, may not know that the cure is so easy to take. And those are the challenges that I think this blueprint helps you think through those processes. And again, it's again overcoming the inertia in the system. And I think we also have to recognize that this miracle cure is spanned a 30-year period. This is the first curable viral disease. And it takes time for people to actually understand, wow, it is actually curable. Now we have to just deliver it through this blueprint.
Can you hear me? It was a great job. I actually read it a little while ago when I got it at work, and just want to thank you guys all for doing it. And I just wanted to focus a little bit on, so I'm a former IV substance user, and the number of syringes per each person per year. You know, it's a lot better than what we used to be able to give out. And I work at a needle exchange as well. I think the number could have been a little bit higher. You know, 365, you get 365 days a year. You're injecting, say, 5 to 10 times a day. So I think that number could have been a little bit higher, and I was wondering if there was any thought put into the cooker, because we know that, you know, hepatitis C is transmitted not only through the syringe. So is it just focused on the syringe, or I think we should be giving out a cooker, a needle, water for every injection. So.
Yes, I think the number of syringes, we thought of it and we discussed a lot about it. And one of the issues is to try to base our recommendation on some kind of data or evidence-based issues. And obviously in the document though, what you're talking about the other things that we have to do around just distributing the syringes is well laid out. And again, we don't say to the provinces how to do it, but we put the good practices and we go forward. I agree with you that the number of syringes is something that is really hard to tackle, and it's the same actually for opioid agonist therapy. In the document, it seemed to us that the WHO was very, very low, and we're already there, and obviously HCV incidence is still high, so something's wrong. So there is a lot of geographical distribution as well. If you have access to programs relatively quickly in some urban cities, then it's not true throughout Canada in semi-urban and rural places. So I guess the document is addressing all these issues as well.
But I would also point out that just with that target, that's actually, so to my knowledge, this is actually the highest number in any of the harm reduction documents that I've seen, is that in terms of advocating for the number of needles and syringes. And actually, we got a lot of pushback on that number. We started out with a slightly higher number and we reduced it, but there was a lot of pushback that why were we aiming so high? That's actually why I showed that the WHO targets didn't, in my opinion, make that much sense. But you're probably right that even where we're aiming is maybe a little bit low. I think just we've gone a little over time. It's been a long day, so I think we're going to conclude. Thank you to everyone for attending, and I just want to. Is Lorraine still here? Oh, what? Okay, I had to look. Well, where's Lorraine? Lorraine, come on up here. We have a little thank you for you. So come on up.
Lorraine disappear. So Brian and I have the privilege of actually recognizing that while there are a lot of cooks in cooking schools and things like that, there always has to be the premier chef. And not only the premier chef had the assistant, and this was already mentioned by Jordan. So why don't we first thank Lorraine for really doing an outstanding job and helping Jordan survive the task that he took on, that he may regret. And for Jordan, like, I'm sure most of you don't realize how much work goes into this kind of a document. and I'm sure his wife will kill him at some point for not attending to her and his kids. So we want to thank Jordan as well for this.
Si je peux dire quelques mots, un projet de cette envergure demande un leadership intellectuel, demande un leadership rassembleur et un leadership énergisant. I will say that leading such a project requires true leadership, intellectually pushing us to be excellent, and I think Jordan was all of those things. And I think that we're sort of providing him with a small token, a uniquely Canadian token. I think the Inukshuk represents friendship, represents safety, represents hope, and represents pointing us in the right direction. And I think Jordan was all of those things, if not more. It was a pleasure and a privilege to work with him, and I speak on behalf of all of the members of the committee in this regard. So please, Jordan.
And we want to give Jordan the last word.
I don't have much to say after that, but thanks everyone, and I think it's time to go to the reception and enjoy the next couple of days of the Canadian Liver meeting. Thanks so much for being here.